So you're about to scrub your first shoulder arthroscopy. Here are the absolute basics you need to know so you don't get completely lost. Now there's two main parts of a shoulder scope. There's the joint space and the subacromial space, and I'll draw those out for you. So the first thing we have is a humerus and a glenoid, the ball and the socket. The other space we have is the subacromial space. And subacromial means it's below the structure called the acromion. So this is the acromion. There's also another bone that attaches, and that's your clavicle. Now, like I said, there are two separate parts to this, and what separates them? A string of tendons called your rotator cuff. So your rotator cuff comes in between. So now you have two separate parts of the shoulder. Now what's going to happen, you're going to go in the shoulder and pretend this is a left shoulder. So if I'm the patient, it's going to look just like this. So this is the left shoulder, the humerus is on the left, the glenoid is on the right. Around the glenoid is this suction cup-like structure called the labrum. And off the top of the labrum is a tendinous structure, because it's a tendon, called the biceps, and specifically the long head of the biceps. So we'll call it long head of biceps. And there's also in the front of the shoulder a very important tendon that's going to come across in this direction. And that is one of the rotator cuff muscles and tendons called your subscap, your subscapularis. So the surgeon's going to go into the shoulder joint, look at all these structures, and one of the common things they do is something called a biceps tenotomy, or just getting a device and just cutting through the biceps. So just cutting it, releasing it, is called a tenotomy. If at this point they choose to reattach it, so you can reattach this end, so this end is just floating free now. You can reattach it either here on top of the joint, you can come out of the shoulder joint and reattach it somewhere lower down. Wherever you reattach it with an anchor or a screw or something, we call that a tenodesis. All right, so we're done with the glenohumeral joint part of the case, and now we're gonna go to the subacromial part of the case. So we take the camera out, we take the instruments out, and we redirect everything. So now we're in a new part of the shoulder, the subacromial space, or the space below the acromion. And what you can do is, number one, you can look down on the tendon. If you're looking down here, you might see a tear. You might see a little tear here, in which case what you can do is you can get different anchors and things. I'll use a purple marker. So you can drill a couple anchors in here with threads and you can repair that. And that's called a rotator cuff repair. Another thing you can do is sometimes this acromion has a bump on it or a hook. Well, you can go in and you can smooth that out. You just get some sort of shaver device and you just thin it out, you smooth it out so it's nice and smooth. The other you can do is smooth out the end of the clavicle, and you can go so far as actually remove this part. You actually get a shaver or a burr and you remove this part, and that takes pressure off of this joint, which is called the acromioclavicular joint. Now, when you're in this part, it can be confusing, and mostly because you can change the angle that you're looking at it. So imagine if I was the patient, this would be the left shoulder. So you're looking straight on. So what's left on the screen is left on the patient, and what's right on the screen is right on the patient. But sometimes, to get a better view, the surgeon will move the camera from this angle, like this, and they're gonna look this way from the side. So all your orientation has to change. So let's draw that view. So now, if you imagine I'm the patient, instead of looking this way, now we're looking this way. So you're looking with the camera pointing this way. And so the acromion is now gonna look something like this, the roof. And what you're gonna see below are the fibers of the rotator cuff. Now, I should probably draw this more accurately. There's a little spine that comes off the acromion that helps divide up some of the tendons. But now, since you're looking this way on the left shoulder, now left of the screen is no longer left. Left is now anterior. So looking to the left of the screen, you're going to be anterior in the patient or that way. And if you're going to the right of the screen, now that is posterior. This is important, the spine, because it will divide the difference between these two tendons. Anterior is going to be your supraspinatus, and posterior to that is going to be your infraspinatus. And then even further down over here, on the posterior side, even further down, you might not even see it, is the teres minor. And altogether, these four tendons, S, I, T, and S, make up sits, which is the mnemonic for your rotator cuff. So now we're looking at the shoulder, and what's hard about shoulder scopes is that you're not looking at the global look of the shoulder, you're looking at it through a telescope. The surgeon's literally looking at a telescope. And if you imagine, it's something like looking at everything with a little circle. So it's hard to know which way is the surgeon looking. You're zoomed in on one very specific part of the surgery. One thing you can use to help know what you're looking at and what direction the surgeon's looking at is something I call the ponytail roll. So pretend I had a ponytail that stuck out kind of the back of my head like this. Well, you looking at the ponytail, can you tell which way I'm looking? Well, the answer is yes. If the ponytail is going that way, if the ponytail is going back, I'm looking that way. If the ponytail is going this way, I'm looking that way. If the ponytail is pointing to the floor, I'm looking at the ceiling, and vice versa. Well, the same thing happens in a shoulder scope. So you're going to have a device that's a camera. It looks like this, and there's going to be like a little handheld part. And one of the inputs, there's a million inputs, but one of them will be lit up. It's going to be bright. It's got fiber optic cables. And think of that like the ponytail. So if this is the camera and the light handle is pointing this way, well, which way is the surgeon looking? They're looking the opposite way. So the eyeballs are going that way. Now let's take another view. The surgeon might spin this around. So now the light source, and it's going to be a wire that's bright. Now which way is the surgeon looking? Well, the surgeon now looking this way. So if the surgeon looking this way and you're at this part of the shoulder, well, that gives you a hint that we might be looking at the humerus versus the glenoid. And the same thing even applies looking up and down, because imagine three-dimensionally, if the ponytail, if the light source is this way, well, which way is the surgeon looking? Well, looking up at the ceiling. And why would you do that? Well, if you're here in the shoulder and you're looking at the ceiling, you're going to be looking at the underside of the acromion, even the underside of the clavicle. And the last example would be if the light source is going up. So the ponytail is up. Well, where is the surgeon looking? Well, the surgeon's looking down. And usually that's going to happen when the surgeon's looking down to fix the rotator cuff. So that is a crash course on shoulder arthroscopy. Let me know if that's helpful. Good luck on your orthopedics rotation.